let's get into some individual pre-excitation syndromes and the distinct accessory pathways in which they are with which they are associated. There are three accessory pathways that we're going to talk about. First is the Kent bundle, second will be the James fibers, and then the third, Mahan fibers. Both the Kent bundle and the Mahan fibers are these kind of extra pathways, extra conduction pathways that connect our atria straight to the ventricles and bypass the AV node. Our James fibers tries to bypass the AV node, but sometimes, depending on the person, just depending on the individual anatomy, might connect right to the bottom of the AV node or the very top of the bundle of His. So Kent bundle and Mahan fibers just go directly into the ventricles. But James fibers, if they are there, if they are present, will connect your atria over to the bottom of the AV node, top of the bundle of His. First, let's set our focus on the Kent bundle, and our Kent bundle is going to be, over here, typically over here on most patients if they have it. And this Kent bundle, just going to transmit. It's going to bypass the AV node and transmit this impulse over to the ventricles and depolarize the ventricles just a little bit sooner, right? So our pre-excitation syndromes say that the ventricles are just being depolarized a little bit too soon, and the Kent bundle allows this to happen. If your patient has a Kent bundle, they have Wolff-Parkinson-White syndrome, or WPW. A hallmark sign of WPW is a delta wave. We'll throw that up on the slide here in a moment, but delta wave, this extra wave, is hallmark sign. Clear giveaway of WPW. Also, some other signs of WPW is a shortened PR interval. So the PR interval is going to be less than 0.12 seconds. We're also going to have a wide QRS complex greater than 0.11 seconds. So we're going to have a wide QRS complex, a short PR interval because of that delta wave. And WPW, strong association with just tachycardia. As your WPW patient can walk around every day, all day long, with a heart rate of 70, but very strong association, very kind of high probability that this patient may go into just a tachycardia at any given minute. So here is your delta wave. So your delta wave is a slurring into the QRS complex. So instead of kind of this normal QRS complex where we just kind of go straight down, straight up, we have this slurring into the QRS complex, and that's your delta wave, and that's a giveaway hallmark sign for WPW. And this is that little bit of that ventricle that's depolarizing just a little bit too early because of that Kent bundle. So that Kent bundle is going to depolarize a part of the ventricle a little bit too early and cause some ventricular depolarization that just happens a little bit sooner than we normally see. And that creates this slurring into the QRS complex and creates this delta wave. If we pull it up, sometimes it's kind of hard to see. Maybe not so clear just on first glance, but we see a little slurring right in lead one here. Usually best seen in the precordial leads, so I can definitely see in V4, definitely see in V2, V3. This slurring, this initial slurring into the QRS complex. So if we see delta waves, we're thinking WPW. If we look at the PR interval, PR is 0.126. That's kind of borderline. That's still getting a little short, and that PR interval is short because of that delta wave, right? So that delta wave is kind of cutting into that PR interval. So it shortens the PR interval. The QRS complex right here, 0.122 seconds. So it's just a little bit wide, and again it's just a little bit wide because of that delta wave that's slurring into the QRS complex. We're starting the QRS complex just a little bit sooner, so it's going to widen the QRS complex just a little bit. So right, hopefully your patient knows that they have a history of WPW, but if they don't, right, we're looking for these things to tell us some history about our patient. we see a delta wave, and we think WPW. Another WPW patient here. Again, we've got delta waves. I can definitely see them in lead 1, definitely see them in V4, V5, V6, V3, maybe a little bit in V2. It's kind of hard, but there are also delta waves in the negatively deflected complexes. So we're talking positives here. But if we look at lead 3, it's kind of like kind of slow slurring into the QRS complex, is slurring into the negative portion of the QRS complex. So a delta wave can be positive or it can be negative. It's just typically easier to see in the positive complexes, just to be honest, but they will be present in negatively deflected complexes as well. There are 3 types of WPW: type A, type B, and type C. So what we're going to do for these types, we're going to look in the precordial leads. We're going to look at V1 through V6. If all those QRS complexes are upright, or at least mainly upright, mainly positive, we have type A. So if we have positive concordance in our precordial leads in the presence of WPW, we have type A WPW. For type B, again looking at our precordials, starting V1, ending in V6, if we have type B, our complexes start negative, V1, V2, and then flip and become positive in the later precordial leads. So we start negative and end positive in type B. So we don't have concordance, positive or negative. We don't have concordance in type B. Type A, we've got positive concordance. Type B, we start negative and end positive. And then in type C, it's a blend of both. We start positive but end negative. Type C, not super common. Usually type A or type B. But type A, we look at our QRS complexes, V1 through V6. If we have positive concordance, they're all positive or mainly positive. We have type A. Type B, if we start negative and positive, we got type B. And then type C, we start positive and end negative, V1 through V6, and then we have type C. Bring up this EKG of this WPW patient again. We know we have delta waves, hallmark sign of WPW. If we were to measure these, we've got wide QRS complex and short PR interval, so pretty confident of WPW. Let's type it. So is it A, B, or C? And we start V1, we go through V6, and all of our complexes are upright, right? V1 has a little bit of negativity to it. V3 has a little teeny tiny little S wave to it, right? But they're mainly upright. So it looks like we have positive concordance. So we have type A WPW. In this next one, again, we have confirmed WPW. I see delta waves here, right? And look, with V1, V2, I've got these negatively deflected delta waves. See, it just takes a little bit, it's a little slurring into that QRS complex. Instead of going positively, instead of going upright, it's just going in a negative direction, but it's still a delta wave, right? And I see delta waves: lead 1, lead 2, little, lead 3. They're there. AVF, they're there. So they're all over the place. I've got a short PR interval. Look at that, 0.10 seconds. I've got a wide QRS complex, 0.16 seconds. So that wide QRS complex, it's not a bundle branch block. It's a wide QRS complex because of the PreExcitation syndrome, because of the WPW, because that little piece of the ventricle being depolarized just a little bit sooner causes a little slurring into the QRS and widens the QRS and shortens the PR interval, cuts into the PR interval. So we've got WPW. Well, what type do we have? We start negative. Again, we're looking at our precordials, V1 through V6. We start negative and then we end positive. So we don't have positive concordance, so it's not type A. But we have type B WPW here because in our precordials we start negative and we end positive. Lastly, we've got a third one. I bet you can guess what type this one's going to be, but WPW again, short PR interval, wide QRS complex. We've got delta waves, we've got slurring into the QRS complex, especially in V2. Look at that big old delta wave in V2. It just like jumps out at you. Look at that. So what type is this? Well, type A. is positive concordance, V1 through V6, all positive, mainly positive. Type B starts negative, ends positive, and then type C is a combination of the two, starts positive, ends negative, and that's what we have here. V1, V2 starts positive, it flips over V3, and then negative, V4, V5, V6. So we start positive and negative. So this is going to be our type C WPW. What are we going to do about WPW though? Most of the time, pre-hospital, they're just walking around with this. They've got, heart rate of 80. We don't have to worry about it. But if they're in a tachycardia, that's usually when we get called out, and then we do have to worry about it. So your WPW patient, hopefully they know that they have WPW. They're going to be on some sort of medication, some daily medication to kind of control those tachycardias, control some AFib, possibly. Surgery and ablation are very common treatments for WPW. Just try to burn away that Kent bundle, right, with ablation. Try to get rid of it. Sometimes it regenerates, kind of grows back, and sometimes it just goes away, and they never have any issues with WPW ever again. But for us, we're going to avoid digoxin. We're going to avoid all calcium channel blockers for WPW. Cannot stress that enough. Avoid all calcium channel blockers. Why? Well, let's think about how calcium channel blockers work. They slow down conduction through the AV node. They slow down conduction. So in the AV node, primarily, they're slowing down things. Well, in WPW, I've got this accessory pathway. I've got this Kent bundle. I've got this side road. Right? So if you cut off my main road, I've still got this side road I can go down. So if we give calcium channel blockers, that shuts down, slows down, a little traffic jam down our main highway in our AV node. It's just going to funnel all this traffic, all this electricity, all these impulses down the Kent bundle, down the accessory pathway, down that side road. And where's that going to end up? It's going to end up in the ventricles. And if all those impulses, all that electricity ends up in the ventricles, you throw your patient into VFib VTAC, and that's not usually a good thing, right? So, WPW, at all costs, we're avoiding all digoxin and all other calcium channel blockers, right? So, Dig and Cardizem and Verapamil, all those, we're just avoiding them. But those are some of our main drugs for tachycardias and like tachycardic AFibs. And AFib occurs fairly frequently with WPW patients. A flutter also occurs somewhat frequently with WPW patients. And these tachycardias pretty quickly, easily go into VTAC or VFib. So how do I treat this tachycardia, this AFib with RVR in a patient who has WPW? I'm not reaching for cardizem because that's going to kill him real quick. The first thing we're doing is we're going straight for cardioversion. That's the first line treatment for these patients. Stable, unstable, everything in between. If they have history of WPW, hopefully they know and hopefully they tell you. If not, you see these delta waves in a short PR interval and a wide QRS complex. They have WPW, they have a tachycardia. Our first line treatment for them typically going to be cardioversion. You can try adenosine, probably not going to work. So follow your local protocols, but what's typically first line, typically what's going to work for these patients is going to be cardioversion. All of that was WPW, Wolff-Parkinson-White syndrome, a pre-excitation syndrome, probably the most common you're going to come across of the pre-excitation syndromes. Now let's talk about LGL, which is another pre-excitation syndrome. Instead of a Kent bundle, this patient has James fibers. And in here, you're going to see, instead of a delta wave, you're going to see a retrograde P wave. That is the hallmark sign of LGL, a retrograde P wave. So a P wave that happens after the QRS complex. So it happens just after the QRS complex instead of just before it. So LGL, a retrograde P wave, You see that, you're like, well, I'm thinking LGL. You're going to see a normal QRS width. There's no delta wave, so it's a normal QRS width. And you're going to see these tachycardias. And the thing with LGL, we've got this James fiber, comes in, it doesn't completely bypass the AV node. So most James fibers connect at the very bottom of the AV node or the very top of the bundle of His right there. So it doesn't completely bypass the AV node. So there we don't have this, we don't have a delta wave. Right? So it's not going directly into the ventricles. It's kind of going back into your main highway. So we see a normal QRS with complex. There's a little bit of controversy behind LGL, right? So if you ask 10 EP docs, you ask 10 cardiologists, you'll get 10 different answers about LGL. The diagnosis of LGL is only possible in the presence of a tachycardia. So if you see a tachycardia and retrograde P waves, we're thinking LGL. Some will say it's just a weird variant of that AV-NRT that we talked about previously with retrograde P waves. So it's just an AV-NRT with a retrograde P wave. Others will say it's LGL and their James fibers present. Um, Others say maybe it's just this enhanced atrioventricular nodal conduction. So instead of the AV node doing its thing and slowing things down a little bit, the AV node just goes like, well, screw it, and lets every impulse through without slowing it down at all. So we get those retrograde P waves. We can measure an atriohisian interval if you really, really, really want to. That's kind of getting deep into the weeds. But with this enhanced AV nodal conduction, that's how we diagnose that. So a little bit of controversy behind LGL, but it still bears discussion. And so if you see tachycardia, narrow complex tachycardia, no delta wave, but a retrograde P wave, we're just going to be thinking LGL. Moving to an even more controversial pre-excitation syndrome is Mahane type pre-excitation, and does it even exist is up for debate and argument. And just ask everyone you know that knows anything about the heart, and you'll get completely different answers from everybody. But it might exist. So we've got a delta wave here. In Mahane type pre-excitation, we have a delta wave, so that makes the QRS a little bit wide, just like WPW. But unlike WPW, the PR interval is normal. So we see a delta wave, which makes our QRS a little bit wide, but we see a normal PR interval. It's like 0.16. So we're thinking Mahane type pre-excitation. This pre-excitation syndrome pretty rare. It's been kind of documented in a handful of people, and again, it's up for some controversy. So those are our three types of pre-excitation syndromes that we're going to focus on: are WPW or LGL, and maybe not Mahane type pre-excitation. Right? You can dig into it if you want. You can read all the papers if you want, but is it a variant of WPW? Is it its own pre-excitation type? Is yet to be 100% determined. But if you have any questions, please reach out and please let me know.